And over the next few months, we had a meeting yesterday. Dr. Graham was at the meeting. The National Hispanic Medical Association is very interested in helping the department with outreach. And there will be campaigns happening in all our regions specifically about healthcare reform. And we're here to help get the word out to our Hispanic patients and our Hispanic communities. So please write down something that you think is important, that we can help with, something that you're helping with, your organizations are helping with. And I have to say, all the national Hispanic organizations were invited to this event. Lots of the organizations are having their summer conferences. I know it's bad timing. The nurses, the National Council of Raza, the LULAC, but all of the organizations, we work with all of them, and I know that they're doing a tremendous job in getting the word out to their constituents already on the importance of taking advantage of the new healthcare reform activities. So let me open it up for questions. If I can have a show of hands, any questions? And I'll repeat the questions so we get it on the tape.
This one is for Dr. Heinrich. I'm Dr. Mary Lou de Leon Saenz from the University of Pennsylvania School of Nursing. Nice to see you again. My question is around the Centers of Excellence. For some reason, schools of nursing aren't eligible to compete for Centers of Excellence, and the dollars amounts that are currently available through the Division of Nursing are for entry level, which are very needed, especially to diversify the workforce, but what's also needed in terms of diversity in the workforce across areas is leadership development. And there's actually no opportunity to develop the leadership potential of minority nurses. I'm representing Hispanic nurses in particular. And so I wanted to know what needs to be done to change the legislation so that we can compete for Centers of Excellence. Thank you.
Do you want to? I'm not sure if you can you pick up without the microphone?
Okay. Nice to see you, Mary Lou. In fact, in some instances, there are centers of excellence. It's my understanding that there are schools of nursing that can participate, but I think the focus is primarily on medicine.
Every occupation except nurses. Osteopathy, dentistry, medicine, but nurses are eligible.
But that's something that I can go back and clarify as well. I think that in terms of making changes in the law, which is what needs to be done if there is total exclusion, you just have to work with your legislators and attend meetings such as this. The thing that I think is interesting about the Affordable Care Act is that there is language in lots of different places that encourages interdisciplinary work, teamwork, and we're looking now at what we can do to further interdisciplinary team core competencies, for example, because we know that as CMS moves forward with innovative delivery systems and more focus on teams providing primary care services, that we have to have the workforce ready to work in these new delivery systems. So it means that we're going to have to make a lot of changes, actually, in the way we train our workforce, and we should try to move away from the stovepiping, that we currently have.
No, I agree. I don't have to say though, but in particular, we're doing a better job of diversifying the workforce, and there's an absolute need for the trenches, but there's an absolute need because of the demography. Our leaders do not represent in our professions the demographic changes in the population. So there's a major need at this point in time to have avenues to prepare leaders to further implement, the president's vision, but also to further implement many of these changes. But there's one thing to learn the basic care, and there's a need for that. Then to get to the next level, there's an even bigger need. when people see nurses and physicians, dentists of color, they don't think of leaders. And I want to change that paradigm.
We would agree. I don't know that we have made so much progress in the numbers of people from diverse backgrounds in our workforce. In fact, as you look at the 10-year trends, 20-year trends, it's rather discouraging. And it's one of the reasons that we will have someone who will lead some special initiatives in the area of diversity in our workforce, and we'll be, in fact, working with the Office of Minority Health, because you all, in fact, have developed a wonderful plan that would do something easier.
Any other questions? Yes, in the back?
Hi, yes. I just had a question directed either to Dr. Graham or Dr. Heinrich in regard to looking at evaluating cultural competency, I guess, kind of curriculum. And what's been my experience, most of it often out when it's targeting Spanish-speaking communities, it's more about speaking Spanish or having an interpreter or what's good like that versus things like people who are identify as Latino may look like me, but they will then be treated more like a path going toward like just treating them as African American versus they're identifying as Latino. And what does that mean? Or like people who utilize traditional forms of healthcare maintenance, like to kind of screen for that. And it felt like, in my experience, those like were missed opportunities because they only saw the person this way. So I just had a question in regard to like, how are you guys going to maybe just evaluate the cultural competency kind of recommendations to continue to further and expand so that these opportunities aren't missed anymore?
So that's an interesting multi-pointed question. It's very important. So you're actually talking about two different things. You're talking about how self-identification versus whether then that person's identified by the system, either by a front desk person or other provider, which is a challenge because there are differences in terms of how people identify themselves and the cultural context in which that happens. And without getting into that data, basically, if I see myself as a something and somebody else sees me as something else, my experiences are going to be based on how that person sees me, as opposed to necessarily how I identify myself. So the context that some people debate is what identification process is important for the experience. Is it what I say I am or what somebody else identifies me as? Because if I think I am something and somebody else thinks I'm another, then they treat me differently based on what they think I am, then that will subsequently affect my experience with that particular system. Does that make sense? So that's one aspect which is separate from the context of how we evaluate cultural competency and the roles and effectiveness of a system of being culturally competent within that paradigm. So convoluted, but suffice to say a couple of things, 3 points. So one, the law does stipulate in section 10334 that the department, actually through our office, establish a series of not standards, but basically talk about the effectiveness of interventions, and obviously to reduce disparities and create a set of ways for us to be able to evaluate and look at those interventions, and cultural competencies are part of those interventions. So that's one concept. So I wanted to separate that from the challenge that we face on the idea of identification. And I'll tell you actually, the challenge of identification goes to section 4302 around this issue of data collection. When we collect data, are we collecting data based on self-reporting versus institutional reporting or what? And if you look at some of the data around how people have comparing people who have self-reported versus people who, based on what some system identifies them, there's tons of discrepancy. And I'm exaggerating when I say tons, but suffice to say lots of discrepancy. But then you have to wonder which avenue is the best way, because like I said before, how I identify myself might be irrelevant if the system identifies me differently in that experience and my experiences are different. So that's a separate challenge, so I want to separate those two. But certainly, again, like I said, in 10334, within that section, there's some wording on evaluation. I would also tell you that the Inspector General are in the process of releasing a report on cultural competency and effectiveness. I think that'll be interesting to folks. If it's not made public already, it'll probably be public in the next couple of weeks. Thanks.
Yes.
Good afternoon. Very informative session. Ruth Perot from Summit Health Institute and the National Health IT Collaborative for the Underserved. The health reform bill that was passed in March was actually the second phase of health reform because in February last year there was the enactment of the ARRA high-tech provisions. And of course that would offer an opportunity to initiate health information technology as kind of a down payment on health reform. It's a question for you too, Dr. Rios, but we are concerned about the extent to which providers in our communities are able to participate in the meaningful use incentive program. Because if in fact health reform, health information technology is going to increase the quality, improve the quality of care given to our communities, and we have providers who are not participating. I mean providers in the broadest sense, not just physicians, but nurse practitioners, dentists, and so on. If we're not participating in that program, then obviously there's a potential for the disparities that we already document and experience to increase. So my question, and it's really not a question, I guess is it important for us to have the resources and the capacity to reach our providers so that they know about the incentives? The incentives are fairly substantial. If you can qualify for meaningful use, we're talking $44,000 for Medicare providers, $68,000 for Medicaid providers, and hospitals going to the biddings. But if we don't get there, if we don't participate, we really could exacerbate the situation that we now see.
Let me just start and then,
Right.
yeah, let me just start and then have Dr. Graham answer this, because I know his office is leading an effort to help this along. The health information technology is going to be the backbone of healthcare of the future. Just like the bank industry has ATM cards, the doctors and the hospitals and the clinics in our country are about to see a revolution in how they issue information. When I was a resident in the 1980s, we had computers that had lab results. That was it. If you went into any different department in a hospital, you couldn't communicate electronically. Now we see hospitals and now hospitals buying doctors, medical groups, and whole health systems being developed, and they all have a bigger need to use technology. And we know that there's a lot more technology in the big health systems, but what Ruth is bringing up is that many of our mom and pop doctor offices or the new advanced nursing clinics that are going to happen, the community health centers in our poor communities are still run with 2, 3, 4, 5 people, 10 people, small operations, very small businesses. They can't afford to purchase the latest technology, let alone maintain and have consultants who have to bring in new software every year. So that issue, this administration has decided to go ahead and give incentives and bonuses to those small providers who will get involved with healthcare information. The bad thing is they're going through it through a regional approach and not going direct to the providers. So you got to get the providers to know that the regional centers all over the country even exist. So it's going to take time. And I think we're here as a Hispanic Medical Association to help with whatever we can do to get our Hispanic medical societies to let their members know to go to those regional centers. But like you said, we look to the Office of Minority Health and the Health Information Technology Office itself, who came to our conference to talk to the doctors at our conference, to ask us or to help us understand how we can be of service. And I understand that there has been a meeting, and we'll try and be at the next meeting. I wasn't there, but we're very much involved and interested in helping. Again, these are the things that are happening right now. Healthcare reform is moving, it's been moving, and we don't want to miss this boat.